we will be taking questions, right? We still have some 20 minutes to go. Maybe I would start at, let's imagine we have roughly here like 27 people in the audience, and if they were like ministers of health of the EU, and it's a very complex issue, fighting against EMR and fighting against COVID at the same time. And you would be asked to tell them 3 things as a guidance. So the ministers of health of EU countries, what would be the 3 top items you would mention? How to fight at the same time against EMR and COVID? What would you tell them?
Hand hygiene is certainly the first point. No, maybe I would say rapid diagnostic tests, because this has become very evident for COVID, that the quicker you identify a patient, the less you have transmission in the hospital or in the community. But for this, you need to have the same strategy of reimbursement. For instance, rapid diagnostic test until recently was free, so you could go to any pharmacy, any hospital, and do your testing free of charge. No. It has to be a prescription from a doctor, but basically it comes to the same. It's free. It's reimbursed. While AMR, every hospital who is doing AMR testing, the hospital has to pay for it. Because everything that is hygiene, AMR, is still, it's kind of mandatory, but it's an advice that the government gives, which means they don't have to put the means at the same side. So it's basically, you have to do it, but you have to find a way how to finance it. And university hospitals, they have the money. Others don't have it, so they don't do it. So if you want this testing to be generalized, you have to give the means to do it. So means is, of course, the money to buy the test. And the third one, I let the third one for Jordi. The most difficult one.
No, in addition to the ones that you mentioned, probably surveillance will be the third one. No? Checking for mainly these intensive care units, the patients who are admitted into the intensive care units, the ones that are colonized by multi-drug resistant bacteria, because it has been shown that we'll say 20% of these patients carrying these multi-drug resistant bacteria are later on getting an infection caused by these multi-drug resistant bacteria. So that will be an additional strategy to follow to try to detect these patients colonized by multi-drug resistant bacteria and try to extreme the barriers to not spreading or not to getting by himself or herself the infection caused by these multi-drug resistant bacteria. So surveillance will be probably the third one.
Okay.
And to do surveillance, you need rapid diagnostics.
Yeah, of course.
Yes. Okay. So we hope the ministers of health would like it. So we'll let them know about it. Okay. So questions from the audience. So we need the microphone. Who has the microphone, please?
Thank you. I have to comment that the most important message that we can transmit to the ministers of health is about the value of rapid test for AMR. Now with the COVID, we proved that the rapid tests help tremendously to the rapid diagnosis. A similar application could be implementation, the rapid test for pyelonephritis, of the NG test, for instance. That is very, very effective. Let's say 20% have ESBL of the community patients with pyelonephritis. That means that 4 or 5 would take carbapenem without reason. So in very few minutes, we'll avoid 80% of carbapenem administration, and the 20% of people will take the correct treatment. This is a message that now the ministers will understand. Maybe last year, 2 years ago, it would be very difficult to persuade to implement in a routine basis in every hospital. Now they will understand. They will give the money. The money is not so much to avoid the days of treatment and the AMR, the increase of AMR due to carbapenem inappropriate use. And another message, more general, is to transmit to the ministers, to the politicians, about the value of microbiologists. Not only the intensivists are the core of COVID, but also the microbiological laboratories. Our value, I think, the public did not understand very well our role in the containment of COVID in this ongoing effort.
Yeah.
Yeah.
Thank you. Your feedback, I think you agree that microbiologists should be valued
Sure.
even more.
Oh yes, much more, and the salary should increase also a lot, and,
They are the stars of modern age.
but the salaries go down.
When it's so popular as intensivists, maybe
Yes.
our reputation is also of some value
Yeah.
Yes,
in the
Yeah.
hospitals.
agreement on that.
Yeah, I fully agree with Spiros about that. I would like to add a couple of comments. The first one is that with COVID, at least here in Spain, that has been an increase of the number of labs, clinical microbiology labs, which are open 24 hours a day, 7 days a week. We are afraid that some of these labs that previous COVID did not have this schedule, they come back to the previous COVID time. So from the Spanish Society of Clinical Microbiology and Infection Diseases, we have written a document called Justification of the Lab, Clinical Microbiology Lab, open 24 hours a day, 7 days a week, in order to try to establish this schedule for at least the university hospital or the hospitals with a high number of beds, because, as I said, before COVID, there were a percentage of high hospitals which were not covering these 24 hours a day, 7 days a week. At the end of Friday, they stop collecting samples, or they collected samples but doesn't follow the sample. So during the weekend, will not have any result. And the sepsis or pneumonia doesn't know about weekends or day offs and so on. That's the first point. The second one is, yeah, I agree that we are very important, okay? And we are generating a very rapid result, but someone in the other side of the telephone need to take this information and adapt the antibiotics. Otherwise, will be useful, our work. So I think that the stewardship team in the hospitals is playing an important role, because we generate the antimicrobial, the information about antimicrobial resistance, identification of bacteria and so on, but someone, at least in our hospital, need to take this information and apply the information, otherwise it will be helpful.
But now we have a chance to
Please.
persuade,
The-
chance to persuade the politicians,
Yeah.
decision-making people. A few years ago it would be much more difficult. Now they understand the value of the rapidity.
Yeah.
I think the ICU, we will find someone in the other side of the telephone. I think in most settings we will find someone to transmit the information.
But just to answer the question for politicians, they understand no. But politicians, they have one tendency to have a very short memory. And also the public in general has a very short memory. In France, at the first wave, every evening at 8 o'clock, everyone opened the window where they were clapping for the healthcare workers and for the microbiologists and intensive care unit doctors every evening. And we had the feeling that, okay, the people were behind us. Then came the second, the third, and the fourth wave, and then you saw people going into nightclubs without masks, without using the hydraulic solutions. So people start, their memories vanish very quickly. And same is for politicians. And what I'm afraid is that once COVID is over, they will come and say, okay, we have spent so many trillions of euros for this. We have now to make some reduction in hospital costs and things like this. And this is something that might become, because at one point we have to reimburse all the money we have invested in COVID. But this is just my pessimistic view of the future, which is probably somewhere close, but I don't know, at least in France.
Also, COVID still persists.
Yeah.
There will be some waves, some more waves.
Yeah, it will, definitely.
Unfortunately, not fortunately, it's an irony, but,
Yeah, but
there's still COVID for the next year, for the
Yeah,
next 2 years. There will
but-
be COVID, so we have some time to persuade people.
yes, but COVID will probably end up like flu. I mean, no, since September we do COVID, RSV and flu testing systematically whenever you have a flu-like symptom. And it's coming into a habit now. It's one of the viruses that will show up probably every fall. This is probably how COVID will end up.
Okay.
I would like
guess.
to raise another point that I think that's very important and links a lot with the project that we are talking about, the AMR detect tool, which is that there is no many papers in the scientific literature showing the real clinical and economical impact of the incorporation of rapid tests. All the papers that are published, or most of them, are just calculating the sensitivity, specificity, predictive values, but didn't touch this problem of the clinical impact and economical impact. And I think that that's very important in order to convince our administrators that we need to incorporate these techniques because they have some clinical and economical impact. No? So, and this is why one of the aims of the
Yes.
project is try to see or to analyze what is the clinical and economical impact of the incorporation of EMR detector.
So you suggest more health economics studies should be done
I
on
think
rapid
so.
tests
In fact, in the new regulation, I think I am not really familiar. I have not read the regulation in depth, but I think that one of the points is this, to show that really it's cost effective, the incorporation of this new technology or new methodology. You know?
Oriol, hopefully tomorrow you'll come up with some facts and numbers, and then we'll see how much money it can save to not just on hospital level, but also on the level of entire health systems.
We will see that next year when we have the data available and we can do the analysis.
Uh-huh. Go ahead, start again for the.
Yeah, Zoltan was talking about the importance of the economic studies, and indeed, they are very important to show that these tests cost effective and to convince everyone to use it for the ones that are hesitant. And we will have this data available next year for the analysis in depth.
Mm-hmm. So it will be easier to go to the politicians, next year with, the calculations at hand, showing how much money they can recover or
Exactly.
save with the rapid AMR test. Yes, absolutely. Yeah.
Yeah, because for instance, our politicians they're using to put medals, no? Because they have implemented what is called the PRAN. The PRAN is the action plan to control or to combat antimicrobial resistance, and they manage to decrease the consumption of antibiotics in animals. And I said, wow, we got it. But then when you analyze the percentages, it started very high. If the average of Europe is here, Spain started consumption of antibiotics, the percentage here very high. So they decreased a little bit, and they said, wow, we have decreased 14%, but it's still very high, no? So you have to analyze, well, when you apply this kind of interventions, the results that you get.
Mm-hmm. Super important aspect, yes. Yes. Any other questions? I mean, Harry, you were talking about the One Health theory, right? That if we give antibiotics to animals and we eat those animals, that we just will be still unhealthy even if we reduce our own antibiotics consumption, right? You had this, a year ago you started this discussion with us. What do you think now about this issue?
Like the One Health
One Health idea, WHO, that as long as we give antibiotics to animals, to pigs and
Yes,
chicken, whatever, we can maybe our own reduction, we'll reduce our own antibiotics intake,
Yes.
but we'll still eat a lot of antibiotics with these animals. So
That's why we have started some studies with the AMR detect tool device in veterinary domains. We start studies in United States of America and also in France to see what is the impact of this kind of test on the, of course, in animals' health, but also in human health. And one thing interesting, it was that in animal, even if carbapenem are not used, some animals have carbapenemase genes. So and this is very important for the owner of this animal if they are comorbidity or sick people. So now in this study, the people do the test for the animal and then they tell to the owner, yes, this animal have carbapenemase, so be careful or test yourself for this problem. So this.
So the animals would be spreading AMR. This is.
We don't know if it's the owner who's who transmit the bacteria, or it's the animal who transmit it.
Yeah, we did a study trying to look for multi-drug resistant bacteria, mainly SVL and carbapenemase producing Enterobacteriales, in the what is called the cloacae, the rectal area of the seagulls in Barcelona. And we found 68% of them carrying ESBL and carbapenemases.
You know the birds, seagull birds, flying
Yeah.
around the city.
So they probably and some of them even they are carrying salmonella, and we compare salmonella from patients and salmonella from the seagulls, and by sequencing we found a salmonella that was exactly the same 100% genomic analysis or comparison with the one from seagull. We don't know what is the if there is a transmission between the human and the seagull and the human, on both are taking the salmonella from the same. That's difficult to say, but that there is some bacteria that can be found in animals. The same clone can be found in animals and human. That's for sure.
Wow. Okay.
And in addition, we did also a study with a public health agency in Barcelona, trying to analyze the prevalence of multi-drug resistant bacteria in rats from the sewage of the city. And we found that I think that was 80% of the rats were carrying multi-drug resistant bacteria. And in addition, we detected KPC producing Klebsiella before it appeared in the clinical setting. So that was like a marker of what will be the future in the clinical setting, because we found KPC, we found NDM, we found plenty of multi-drug resistant bacteria in the intestinal tract of rats in the sewage of Barcelona.
Wow.
So it's One Health, but it's so complicated, and there are so many factors that can affect the dissemination of multi-drug resistant bacteria, that to control all of them and to try to barrier or to stop the dissemination is really difficult.
So you can imagine we are now in a hospital, and I guess there are also some multi-resistant bacteria in this hospital, and in the sewage system, the rats would be infected and take this away across the city. This is what would happen, not just here, of course, but in other cities as well, in other big hospitals.
Yeah, in fact, when we map because I didn't know, but the rats doesn't have. So we are not going from one part to another part of the city. They have a radius of 100 meters, no more than that. So when you map the ones that they have carried more multi-drug resistant bacteria, were the ones closer to Hospital Clinic, Hospital de São Paulo, Hospital del Mar. So probably these bacteria, of course, these multi-drug resistant bacteria are coming from the hospital.
So you have kind of healthy rats far from hospitals.
Yeah.
Okay, good to know.
Same for humans.
Yeah.
If you're healthy, avoid hospitals.
Yeah, it's true. Okay,
so this means in Spain your beaches are contaminated with ESBL producing E. coli.
Probably. Well, I don't know. The seagulls defecate in the sun of the beach.
Yeah,
and so
then
on.
you come and play with the sand.
Yeah, and also
And put your fingers in your mouth.
No. There is an interesting data as well. In pigeons in Barcelona, we have found a lot of Campylobacter.
Oh.
If you read a manuscript or a book on microbiology, and you test or you check how is Campylobacter acquired, you said through the
Food chain.
No? But imagine that the sand in the playground of the children is contaminated with Campylobacter.
Yeah.
The children take the sand and put the sand on their mouth, and can be a direct contagion or contamination of Campylobacter. It's not a food truck or a food chain.
And you have a lot of food trucks,
Yeah.
which with open sky, and you can imagine that the pigeons fly over and scary.
Yeah.
Wow, interesting questions. Antonio, you have a question, right?
Yes, it's probably a question and a comment. The question would be more regarding how clinicians still do the empirical decisions for implementing antibiotic therapies that we have seen since last year. The early reports coming from China were already showing that sepsis was viral sepsis and not bacterial sepsis. There were not a lot of co-infections with bacteria. And these data accumulated since March, April 2020, but we still see this reaction from let's say, those clinicians that are more involved in antimicrobial stewardship programs still fighting the unknown with antibiotics, and of course imposing pressure in the hospitals that can lead to selection of antimicrobial resistance. While the data that you showed, and you clearly demonstrated that probably GPs, which let's say are at another different level, were not making that pressure. There were, of course, many less cases of respiratory infections in the community, but probably you did not see them answering with the same type of let's go and just, if you have COVID and you're feeling bad, let's use antibiotics. So I saw somehow there the difference between the GPs and the intensivists, how they address the problem, and if this is, so the question is, does this represent the fact that there is still a lot of work to be done within the hospitals to convince or to transmit the message of antimicrobial stewardship and controlling providing the therapy, and how fast or what will be the effect of rapid tests in contributing to this earlier support of information for the decision to scale down therapies. On the second note, which is more a note and comes from the excellent presentation that Yeri made, the Chinese versus European, quality versus quantity. And of course, we are bombarded in Europe with less than optimal, if not low quality tests coming from outside or from Asia in particular. It's demonstrated, the data, that the solid product coming from NG Biotech and other European companies had much more validation about the specifications, and I think this will be one of the opportunities and the contributions of the IVDR regulation, that will impose more strict access to the European market to these type of tests. Of course, in terms of pandemic, we will always need a fast door, because we don't have time to do the validation. We have to come out with solutions and then later on go through the validation. But the balance between having a CE IVD and just bringing the test quickly to the market, and for the business side, companies like NG Biotech, that we know we have the high quality and the best performance kits, and then we have to fight lower performance and lower quality just because we don't have protection from the regulatory legislation. So for us, that was probably my comment for the first intervention, why we favor to go with IVDR, because we know in the long run the best will be selected, and we will avoid that fast competition, companies show up and disappear. So thank you very much for the data with the COVID, because it really shows that quality is important, but unfortunately there is no mechanism that the government can access to say, okay, these tests are not at the quality that is needed, and they should get out of the market unless they are really bringing problems. But that was the note.
Just to remind you that AMR detect tool will detect resistance and not susceptibility. It's not because your test is negative that the bacteria will be susceptible. So basically, for downscaling, the only way to do this, you need rapid susceptibility testing, because you detect genes, and even when you detect genes, you're not 100%, for instance, OXA48, 40% of the OXA48 produced are susceptible to carbapenems. But yet, you may select carbapenem resistant during treatment. So that's why we avoid using carbapenems for OXA48. And it's not the best treatment in animal models. But you detect resistance and not susceptibility. And this is something that is very important. But yet, it's very important to detect these enzymes, because for treatment and also for hygiene measures. And for COVID, you're right, at the beginning, it was a big mess. And many tests were sold and used, and they were of bad quality. And I know in Spain you have bought many of those, and they turned out to be very, very bad. But then things came into place, and the government asked Pasteur Institute to validate. It took a long time. They didn't have the samples to do it. But now the validation is much better. So now many of the tests that were of bad quality were removed and or improved in order to satisfy the rules of the health system. But you're right. I mean, having this in place this European guideline for diagnostic tests will certainly help to have good quality tests. But it will slow down a lot because there is already a huge bottleneck and there are many tests that will be, so the first test, it will take probably years to get the validation.
Yeah, and this situation when you want to perform a fast track acceptance of the potential new kids, as Thierry mentioned it before, some of the kids were validated with 20 samples or less. I mean, I think that the European Union needs to mark a minimal requirement to this kit to be accepted. Otherwise, all the kids will be accepted, and the ones that we had first in Spain that were for detection of antigen detection, the sensitivity was around 50%.
Yes, I
or
remember.
less. So it's nothing. Nothing.
It's
They
useless.
spend a lot of money buying that, so that's crazy.
Yeah, no,
Okay.
it's very easy to change the specification of these assays because we have seen that if you use a lot of challenging samples, such as malaria, people that had malaria, these sera are usually cross-reacting a lot, and if you don't choose any, you won't have false positives. And if you choose a lot of them, you increase your percentage of false positive. So I guess, yeah, we need to have rules, how many of which samples have to be tested in order to have the best specifications.
Sure.